Welcome back. In today's lesson, we will cover the basics of peptic ulcer. Now, before we start, ulcer is defined as discontinuity of any epithelial surface, whether that's of the skin or the epithelial lining of the gastrointestinal mucosa or the urinary tract or the respiratory tract. And the name peptic comes from the fact that peptic ulcers disease is caused by acid and pepsin digestion of the mucosa that will lead to ulceration. Now, we need to mention at least the extent of the disease, or in another word, the epidemiology. Ulcer disease used to be extremely common. We'll explain that to you in a minute. But currently, we have 500,000 people diagnosed each year in the United States with some form of peptic ulcer disease, and 9,000 of those die as a result of its complication, and the complications are either perforation or bleeding, usually. We know now that 90% of duodenal ulcers and 75% of gastric ulcers are caused by a bacteria, which is Helicobacter pylori. In the past, there was a variety of theories about the cause of peptic ulcers and how to treat it until the late 80s. Historically, the first time ulcers were mentioned was by Marsilius in the 16th century, who described a gastric ulcer on an autopsy specimen. And the disease remained there untreatable and by and large unknown until the beginning of the 20th century, when things have improved with anesthesia and intensive care and antibiotics and so forth. Until the 1980s, surgery was the mainstay in the treatment of peptic ulcer, and that surgery, which I will just mention it, we won't cover it in this lesson, and I plan to cover it in coming lessons. The surgery used to be in the form of truncal vagotomy. There is a selective vagotomy. There is antrectomy, which is the distal part of the stomach. These were based on the theory that ulcers are caused by acid oversecretion, and the mechanism that produces the acid in the stomach is controlled by the vagus nerves and by what we call the G cells in the antrum, which are the gastrin-producing cells. And gastrin released in the circulation act as a hormone which will go and work on the parietal cells in the body of the stomach to produce excessive hydrochloric acid. So that was the treatment until 1987, when Marshall and Warren, Dr. Warren and Dr. Marshall in Western Australia discovered that, in fact, most of ulcer disease is caused by a bacterial infection, and that bacteria was described as H. pylori, and hence antibiotic treatment became possible to treat the ulcer and mainly prevent the recurrence by eradicating H. pylori. And then we have the PPI's production, which is the proton pump inhibitors that appeared mainly in the 90s and proved to be very effective in causing healing of the ulcers, along with eradication of the H. pylori. We will need to understand the pathophysiology that the peptic ulcer. How does peptic ulcer actually form? We know that in general there is excessive acid secretion, and the acid and the pepsin will lead to digestion of the underlying mucosa of the gastrointestinal tract. Now, the mechanism where H. pylori work is the fact that it produces potent enzymes, and these enzymes are toxic to the underlying mucosa. But mostly what it does, it produces, and that's how it does survive, produces an enzyme called urease, and that will split ammonia and lead to the production of bicarbonate, and by that way it will create an alkaline microenvironment within the stomach, and that's how it protects itself and lives in the mucosa to avoid being killed by the low pH in the stomach. The toxic proteins that get secreted by it are three. Mucinase, and this will degrade the glycoprotein component of the mucus layer, which is one of the protective barrier mechanisms to protect the duodenum and the stomach lining from being digested by the pepsin and the acid. It also produces the platelet activating factor, which lead to microthrombosis and ischemic changes in the mucosa. The last one is phospholipase, and phospholipase is very damaging in a direct way to damage the epithelium and cause ulcer formation. There's a theory that there might actually be a local immune response and reaction to the presence of H. pylori, where the body form an autoimmune response and damage the mucosa. The indication to that, or what led us to believe that, is the fact that almost always with H. pylori there will be chronic active gastritis on the stomach if you take a biopsy. There is another theory how H. pylori work. It might kill the D cells in the antrum. As we said, the antrum, we have got hormone-producing cells. We got the G cell and the D cell. The G cells produce gastrin that lead to increased hydrochloric acid secretion, and the D cells produce somatostatin, and somatostatin work to suppress the G cells. So, in theory, killing the D cells by the H. pylori could lead to ulcer formation. Now, H. pylori only lives in gastric mucosa, so you would ask, how does it lead to ulcer in the first part of the duodenum? And the theory is that H. pylori would induce gastric metaplasia in the first part of the duodenum. There is another possibility, and that possibility is the fact that gastric mucosal heterotopia is relatively common. It's sometimes when biopsies taken from the duodenum, we find gastric heterotopia, presence of gastric mucosa in the first part of the duodenum. And that how it leads to duodenal ulcers. Now, the rest of the duodenal ulcers are those that are not caused by H. pylori. And the main player in there is the non-steroidal anti-inflammatory drugs, Brufen, Voltaren, indomethacin, and the rest of them. They play a major risk factor because non-steroidal anti-inflammatory drugs work mainly by reducing the secretion of prostaglandin, and prostaglandin, particularly prostaglandin A, is a major protective factor for the mucosa to promote its growth, replication, and ulcer healing. Now, the risk of having ulcer is proportional to two things. One of them is the dose, and the second is the duration. As the dose increases and as the duration elongates, the risk of having ulcer increases. That's why we ask patients who need to be on non-steroidal anti-inflammatory drug for any significant period of time to be on proton pump inhibitors to reduce the risk of having peptic ulcers. Or there is a medication which is prostaglandin related as well that can be occasionally used in the form of prostaglandin E. Most ulcers will happen in about a week or two after continuous use for non-steroidal anti-inflammatory. Commonly, this is used for joint pain or muscular strains. The most usual site, the typical site for ulcer that's caused by the non-steroidal anti-inflammatory drugs is the pre-pyloric region, and it can bleed and it can perforate as well. It's important also to mention two more types of ulcers: stress ulcers and stomal ulcers. Now, stress ulcers, from their name, they are induced, or the pathology happens in people who are extremely unwell, particularly those who had major surgery or major trauma or severe pancreatitis or major burn. So you see that all these patients will be put on proton pump inhibitors to reduce the risk of having peptic ulcers. It's called stress ulcers because in the past it was thought to be related to increasing level of cortisone in the bloodstream as a defense mechanism against any stress. But it's in fact related to the circulatory changes in severe unstable hemodynamics or patients or severely ill patients. Stomal ulcer is another term that we need to keep in mind, and from its name, it happens at a site of a stoma, and that site is more or less mainly occur at the place where we do a gastrojejunostomy for a variety of reasons, and that will happen after either a partial gastrectomy or after a Whipple surgery for cancer of the pancreas. So these patients who have a gastrojejunostomy of any sort, they will need to be on proton pump inhibitor for life. Otherwise, they will get ulceration. Now we will move on the presentations of peptic ulcers. Pain is the main symptom. And that pain is usually epigastric. It's constant agonizing pain and usually well localized to the epigastric region. Very often it is relieved by food, and food will neutralize the acid, and that will lead to relieving the symptoms. You often see people with duodenal ulcer gain weight because that's the way they could control their symptoms. Alternatively, it could be in the form of upper GI bleed, and the upper GI bleed could happen in either a coffee ground vomit or vomiting bright blood, hematemesis, or melena, which is tarry dark stools as a result of upper GI bleed. And these are emergencies that will need to be dealt with, whether endoscopically or surgically. It depends on the patient, and we will explain that in the next session. Ulcer could perforate, of course, and the first presentation could be perforation. Now, gastric ulcers and duodenal ulcers in particular, if they are chronic and recurrent, and they can lead to scarring and stricture of the first part of the duodenum, which could lead to gastric outlet obstruction, where the patient is vomiting continuously. There will be more elaboration on this, hopefully, in future lessons. Now, how do we manage ulcers? If we suspect a patient has an ulcer, either by having pain or hematemesis or melena or coffee ground vomit, the gold standard is upper GI endoscopy. It's an easy procedure. It doesn't take very long time. Very safe. We introduce a fiber optic gastroscope, and that can visualize the mucosa of the entire upper GI from the oropharynx down to the second and third part of the duodenum. What do? We visualize the area. We notice if there are ulcers. So the first part of the duodenum in here will be the most common site, followed by the antrum of the stomach, in particular the pre-pyloric region. What do we do if we see an ulcer in the duodenum or the stomach? So we'll do a hot test, which is checking for H. pylori. We would take biopsies from the gastric ulcer, and there are two reasons. One of them is that if there is H. pylori, we might be able to see it microscopically, and the second reason is that we want to rule out malignant gastric ulcers because clinically it will not be possible to differentiate between the two. We do not take any biopsy from duodenal ulcers because we know duodenal ulcers are benign. We only do take biopsies for duodenal ulcers if they recur, if there is recurrence of the ulcer after adequate treatment. There are other ways of diagnosing the presence of H. pylori in the stomach, and that can be in the form of serology or a breath test, which is checking for urease in the blood, and they are pretty accurate. Now, we found someone with an ulcer, or we found someone with H. pylori with a bit of chronic gastritis and no evidence of ulcers. We will need to treat them, and that will be more or less the same. So they will get eradication of H. pylori, which is an esomeprazole or any PPI medication like Nexium or pantoprazole, and that's usually in the form of 20 milligram twice daily. We put them on a gram of amoxicillin twice daily, and they will have 500 milligram erythromycin daily, and that goes for a week. So it's called HP7, Helicobacter pylori eradication 7 for 7 days. Now, if the patient has an active ulcer, we will extend the duration of the PPIs on its own for 6 weeks. Now, what do we do if we have diagnosed someone with an ulcer in terms of follow-up? Duodenal ulcers, they will heal, and if the patient is asymptomatic after 6 weeks, we reassure them, and that should be the end of it. Patient with gastric ulcer, they will always need to have a follow-up endoscopy at 6 weeks' time to ensure healing. And the main reason is to exclude gastric cancer in this situation, because non-healing ulcer will raise the suspicion of adenocarcinoma of the stomach, and we need to take thorough biopsies from the area around the ulcer and the ulcer itself. Thanks.